What'd you all think about that? So Miss Florence is now 85, I believe. She's about this tall and about this wide. I'm telling you, she can knock everybody out in this room. And her sister-in-law, Laverne, is, I think, also about 85, 86, and they both have just recently had some health problems, but they're still very passionate and very involved, and I know Ron and Tiffany still work pretty closely with them, and I thought it was just a really good story to start the day, so hopefully you guys appreciated that. So now I'd like to welcome Dr. Smith back up. We're going to get into some institutional environment information for you this morning. Also, before we get started, I just want to give another round of applause to GBT and Dr. Laura Pridgeon for putting on this event. By now, you all have talked to her, I'm sure, so, but she probably will be leaving us right around lunchtime, so I wanted to give her another shout out before she left.
So you saw the video, and it told you a story about the Virginia experience. Just a reminder, it was 19 programs that got this initial money in 1972 under the Nixon administration, and let that be a lesson. Yeah. You know, we can talk about how things are and they shouldn't be the way that they are, but in the midst of then what was considered a hostile environment, Florence persevered. So the program here has been functioning since the 1960s. I came in on the tail end of Dr. Scott's career in 1991. By that time, the grant money was running out. So the federal money had dissipated to the point that the state needed to pick up and pay for the VCCAPE program, the screening program. And Joan was in the Department of Health at that time. Joan, do you want to say a few words about how the program was funded by Virginia Department of Health?
You have to understand I was a new grad, so I wasn't in the know, but one of my colleagues was very involved that I kept up with over the years. And actually going out to the neighborhood, she mentioned Gilpin Court. I've been to Gilpin Court to do it's one of our projects, and then we actually went into the projects. I'm sitting here going, oh my gosh, I remember that.
Yeah.
Where we did the testing, trying to locate of course, remember, we didn't have newborn screening, so we didn't know who had sickle cell except who had come to the hospital, of course, and then trying to do this education about the trait. So I'm sitting here, even though had been involved with Ms. Cooper, but I was part of some of the stuff that was the result of the work that she did. So I hope you appreciate, I certainly appreciate it, because I had not seen this, even though I knew about it, the hope that I hope it puts in our hearts.
Yeah.
Because she started just these two people that worked together and just kept trucking along and fighting resistance. And even though we don't necessarily do that today, because I think we have our newborn screening, for one thing, it really gave me hope. And being a little neophyte nurse out in the projects, actually that's where my role was in. I was just out in the neighborhoods. I went out with Stephanie Ferguson when Stephanie and I were new graduates, and we were out in the projects in Richmond City.
Fearless.
Yeah, amazing, isn't it?
It's good. So there you see it. Somebody out there in the inner city doing testing, fearless. And the state passing laws and other states beginning to pass laws. And by this time, only 12 states had passed laws mandating newborn screening. 12. And I came to a program, Florence likes to say, that God sent me. And she likes to tell the story of sitting in grand rounds. I sat beside or behind her and her colleague, Jean Chipman, and I was new to the faculty. And she likes to tell the story that I said, "Excuse me, do any of y'all know Florence Neal Cooper Smith?" And Florence says, "Well, that would be me." And the rest is history, as they say. So she's kind of like my mom. We started with a clinic with myself and a nurse practitioner. And the nurse practitioner, I should give credit to Paul Swerdlow. The nurse practitioner was not something that I did. That was something that Paul Swerdlow did. And he was my predecessor. Between Dr. Scott and me was another white doctor who's now in Detroit named Paul Swerdlow. He was in the division of hematology. And he was running the clinic when I got there. I came and I was sort of his understudy. And then he went back to what is now Wayne State in Detroit. And if you don't know anything about Detroit, that's where Dr. Charles Whitten, who most would consider the national father of community-based organizations in sickle cell disease, that's where he's from. Wanda Whitten Sherney, his daughter, is carrying on his legacy. What we decided to do was to start seeing adult patients. We had 200 patients in the adult clinic at that time. But we noticed that the clinic was growing, and it was mainly growing from these children who were surviving childhood sickle cell disease. And they were coming at us, or worse, not coming at us. And we needed to develop important program, transition program. So we were one of the first in the country to focus on sickle cell disease, pediatric to adult transition. A guy by the name of Joseph Telfair was doing the research at that time in the United States. In England, it was Dr. Annie, A-N-I-E, 4 articles in the literature on transition in sickle cell disease. And so we started the program. We hired somebody named Shirley Johnson to work in the transition program. We got a grant from a foundation, $50,000 a year. They thought it was a risky endeavor, the foundation did, but they were willing to take a chance on us and said, you know, we see the need. We see the need. We see the lack of resources, and so here's some money that we hope can get this program going. That was a local foundation, the Richmond Memorial Health Foundation. Problem was, it was a grant. So immediately after you get it, those who write grants for a living, immediately after you get funded, the next thing you do is start planning and writing the next grant. That's it. That's how you live and die by the grant. You have to start planning. So I want you to hear that message today, and I want to enlist you to become grant writers if you're not. You want to go do something, don't wait for somebody to give it to you. You go out and you find possible funding sources. Maybe you're not a writer yourself, but you can plan. You can dictate into a machine your ideas. And there are professional grant writers out there who want to help you. They're righteous do-gooders who write grants for a living, sometimes for free, that can help you. So let that be a lesson. And you're looking at one of them. I mean, that's what we do. Grants are us.
He could be your ghostwriter.
Done it a lot. Done it a lot. And at this point, you know, what do you get for being our partner? At this point, what you get is access to my file cabinet. Got a lot of stuff in there, 30 years worth of stuff. And all we're asking is, when we partner, you write us into your grant somehow, some way, to help you execute it. And we have a long list now of skills, abilities, and personnel that could help you with some part of your scope of work. The next thing we did was we focused on the health of the adult patients who made the transition. And that's what this term R18 is all about. What we learned was that a lot of patients were fearful of taking hydroxyurea, as you have learned, that doctors were fearful of prescribing hydroxyurea, that patients were not in adult centers of excellence, even though they existed in the state. And at the time, we actually boasted 3 adult centers of excellence. And I won't even tell the story of Norfolk. We could talk for a whole hour about that. It's got its own politics. It's got its own ups and downs. It's in a down period right now, just to be honest with you. All the patients are in the eastern part of the state. There's not a doctor for adults. There's a nurse practitioner and a doctor looking on. That's about it. Those patients are journeying through the tunnel on I-64 and driving 100 miles up here to see me. Not ideal. So that would be one of my next projects, hint, hint. Anyway, patients in the state needed to be on hydroxyurea, needed to be in care. So what we decided to do, and I got lots of help from the NIH, in particular Dr. Ellen Werner, herself a righteous do-gooder, with a chronic disease, I don't think she would mind me sharing, that is not well cared for by her providers. And so she could emote with me, empathize with the patients with sickle cell disease. She went out on a limb and held this little summit for the patients at the NIH. It was a gripe session. You know, they got to say everything. I remember exactly when that was. It was 1992, something like that. They got to say exactly what it was that they wanted. She said, I'll get back to you. She was right. She got back to us. And a whole line of programs that she personally advocated for and fought for got put into place to deal with sickle cell disease on a research point. So she was trying to take the gripe session and turn it into what? Data. You have to develop a tool. It's called Ask Me. That's her. And what Ask Me does is codify, datafy gripes, including quality of care and access to care and health-related quality of life for sickle cell disease. Parallel to that, I'm writing a grant with her tutelage to go out and get these community health workers, and Joan can remember our early days of combing the literature and Shirley combing the literature and Shirley telling us of her experiences. That's how we got into this game. So, Dr. Lopato came along, started helping me in the clinic. We then got funded for that grant after a couple of times around. Can't remember. No, actually, it was the first time around. It's the only grant I ever wrote, and the first version of the grant got funded. Not only that, it got the best priority score I've ever gotten. Anybody know about priority scores? Anybody in the audience I don't want to be the one to explain what a priority score is. Anybody want to explain what a priority score is?
The lower it is, the better it is.
That's the key. Normally on a test, the higher you score, the better your grade, right? Priority score is the other way around. The highest priority grant gets the lowest number. 10's perfect. 90, don't quit your day job. We got a 16. 1-6. That's high. That means they thought it was almost perfect. So it was very encouraging to us. We were jumping up and down. We said, oh my God, this is going to cure cancer. So we thought. Shirley said, oh, I got a full-time job now. And we started working to do the grant all over the state of Virginia, including Norfolk. And I'm going to leave a whole chapter out of doing the grant. That's its own chapter. Just pull us aside one day, we'll tell you about the grant. Yes, please.
This grant, yeah, okay. You never know when you're going to be in the right place at the right time. And the seed for this grant, you remember, Dr. Smith, I was working with the program, the pediatric side, but we got together with the CBOs and everybody, and we had a conference. In fact, the hotel we had it in has been torn down. I didn't really know Dr. Smith that well because I worked with the pediatric people. But all of us were there, and he, of course, was speaking, and we had Dr. Werner in it.
She came.
She came and spoke, and in her talk, because of some of the work she was doing, she kind of made a challenge to us. Is to what, and we had parents and everybody there.
It was mainly a CBO meeting.
Right, it really was.
Let's be real about this.
And
this was the statewide CBO sickle cell meeting.
Right.
And Ellen came and
came,
challenged us
to do something. And we had discussions around the room. And that was probably the first real conversation that I'd had with Dr. Smith.
Yeah.
And then we involved Dr. Werner, and we went up. And we're saying, and I was like, oh, we could do better. Me, y'all figured me out. And she was like, oh, that would be great. And that's kind of the seed. So you never know. Conversations can then lead to things down the road. I just had to add that because I remember
and Dr. Telfair was at that meeting. I remember that as well.
Yes, that's where I met him. That's right.
Dr. Telfair, the person who did all the transition screening tools and all that, he was at that meeting as well. We had invited him. So you get the point that, networking, I hope you understand. Are y'all catching what's happening here? You guys are an army. Did you catch that? And y'all don't even know each other, some of you. But you're an army. You just have different outposts in different forts. So this is your support system right here. We talked this morning about Ray's idea. Said we need a therapy session for us so we don't burn out. Soldiers need relief. All right, I'm jumping around a bit. Sorry. Didn't know it was going to be this emotional. So gradually, as that grant went along, we got help. We got help from Dr. Lopato. We hired another outpatient nurse practitioner. We did analysis, data, analyzing the grants. I left out the Pisces grant completely. Don't even ask me about the Pisces grant. That was another one. And then we said, let's go to the hospital and let's prove to the hospital that this federally funded program is something that they should pay for. And they said, oh yeah? We said, yeah. They said, well, prove it. Well, the problem was we didn't have the data they needed to prove it. They needed to know if on their patients, their outcome data that they wanted to know were going to improve. The grant was not for that purpose. The grant was to be out into the community, to get people into care, and to get people on hydroxyurea. So we got creative, and we borrowed some time and effort of our federally funded grant personnel, and we said, over here on the side, can you run a little pilot for us on the top 5 highest utilizers in our healthcare system? Stephanie was one of those people. And can you show in a year's time what paying attention to those top 5 highest utilizers will yield? And I think by now you can figure out the answer was quite a lot. It was $330,000. Just managing the top 5 highest utilizers. Cost avoidance of $330,000. So we showed that to the hospital. We didn't tell the feds. And the hospital said, all right, we'll give it a shot. We'll give it a go. So the first version of the adult sickle cell medical home was funded at a level of $400,000 or $500,000, something like that, and a modest number of additional staff. And the data you saw in your book is the outcome of the first year of that program. That's how we got to the 1.4 million in savings. So what you're looking at is the annual report for year 1. We now have a manual of operations, and I don't want to just say we'll give it to you, but if you're going to be our partner and you're writing a grant and you need an engine to show the methods of your grant, we'll collaborate with you. We'll share with you. So we really are looking for partners. And we think you should do that. We think that this should be replicated. We think that this can be replicated. And we think urban academic medical centers or just urban medical centers across the country can replicate many of these things, already are doing so. But I feel that it can go even further. I think I'll stop right there and take some questions. Yes.
Do you think to replicate the program that it can stand alone, or does it have to be in conjunction with an academic institution?
It's a good question. It's easier to get federal money if you're at an academic institution.
Got it.
It's easier to get foundation money if you have a fiscal entity that has its own infrastructure and is in existence already.
Got it.
On the other hand, academic medical centers don't know how to do this.
Obviously.
So you got to have a partnership somehow. You've got to have a partnership where the academic medical center or the hospital trusts you enough, like Dr. Iffy, trusts you enough to give you control over a set of resources and a place to put the money if it's awarded, and a fiscal administrator to keep your butt out of jail. You do not want the feds down on your butt
Not at all.
for mismanagement of funds. And if you're a small CBO,
It's better if the funding would go, like for the CBOs, we want to try to do something where we can help our CBO by maybe issuing a subcontract for something that maybe we write. which would mean that, but then on the other hand, some grants don't want to fund an academic institution.
Right.
And would rather fund a
Fund the
CBO, so
Yeah.
we would be willing to help
Now,
with that too.
I want to speak for pharma, but not speak for pharma.
Pharma's here.
I know. Pharma is interested in selling product. When they give you a grant, they want to see variables improve that, if they improve, will lead to more sales of their product. So enlightened self-interest. If I have a drug that sickle cell patients need to take, and sickle cell patients won't take any drugs that they need, I should fund programs that get patients to take all of the sickle cell drugs that they need, and a rising tide will lift all boats. Their health will improve, and my profits will improve. That's just, I can't, Laura can't, she can't say that. I can say that though. So when you go to pharma, you need to think about what their bottom line is and how what you're doing is going to marry your interest with their interests. Okay? And they're a little more forgiving and a little more risk-taking and might fund a CBO aside from an academic medical center. But they want to see delivery of product. They're not interested in just throwing money out there and not getting a return on their investment. So what you've got to deliver for them, ideally, is some data that says this will be a good investment. This is before you ever get the money, by the way. So it's a vicious cycle. And then you have to show them that I've got the people, I've got the organized processes, and I know what I'm doing, so that at a time certain, I'm going to do some measures, and they're going to be improved. And the improvement is going to empower patients, improve health, set the stage for you to be able to sell your drug more and better. Laura cannot say that, but I can say that.
So I'm going to kind of try to walk the middle in my question, because I know that I have, at least in my state, a unique position where I have one foot in the clinical setting and one foot
Yeah.
in the
That's
community
unique.
setting,
That's unique.
right?
Yeah.
And Dr. Laura and I were talking about it maybe last night, this morning, I don't know, they're all running together. But last year I did an NPR story and I called out our academic medical setting.
Mm-hmm.
And the backlash of that was kind of big. It was huge. They were calling me, they were emailing, they were not happy with the truth.
Okay.
But as a result, 1 year later, they've now hired a physician who is tasked with creating some sort of comprehensive adult medical center.
Oh, so it's coming clear. Can I tell the other side of that story?
Sure.
What the heck? Okay, so we at ASH evaluated about 50 applications for adult medical homes. And one of the winning applications was in the cold, snowy state of Minnesota from a doctor that we didn't know much about. We're going, what the heck? Where did they come from? How's their application so good? So the answer is you agitated and made them. Yes, I think that deserves. Thank you for putting that together, because I was going, what got into Minnesota to make them
You should say that.
want a medical? Oh, I'm not saying that. No. That's within the family.
Are we going to see you in DC then in November? Or just
So that's the other piece of my question, is that as I'm watching this unfold, I see where they could potentially scoot me out
They could.
So there's only 3 spots
That's right.
that can go.
That's right.
I was the 4th,
That's right. Even though it was your idea, sort of.
right?
I got it.
And we'll come back and we'll tell you all about it.
I got it.
Now, while I've been here, I actually emailed Dr. Boucher. I said, oh, I know I won't be in DC, but guess where I am at? So we should talk when I
Yeah.
get back.
And I got your back. I got your back. I won't let them scoop you out. I
So
will not
that's
let them
my
do it.
question for so many of us in this room. I am not unique in the fact that I'm a fire starter.
Yeah.
Right?
Yeah.
But I also carry the hose that can help to extinguish it,
Okay.
if you let me.
Yeah, I got you.
But how do we strategically maintain our positions so as not to get cut out? Because when the dollars come down in academic centers, all that money to keep the lights on and the cushions dirty, you get cut out. And we have to be able to strategically think ahead of all of that.
I hope you got that on tape. That was good.
I'd like to piggyback on that just a bit, because one of the things that you said that I think is really important is when you are writing a grant for an academic institution, you make sure you write, not, well, yourself, but you make sure you also write the lights on and the sofa, because that fringe rate at our institution is 55%. So if you don't write in that fringe rate and you get, let's say, indirect rate, then let's say you get, I'm just going to use a simple number, $100,000. Over half of that money goes to people who have nothing to do with the project.
Nothing.
So sometimes people are not good about writing in that indirect rate. So just be very careful about that. That's one of the reasons you can get written out, because of course, no offense, they're going to pay them first.
They are.
Because they have to have a PI on the project, they want a physician on the project, they need to have the clinical piece.
Yep.
You can get cut out of that really quick.
So, okay, so are you willing to share a little dirty laundry? Sure. Figurehead or real deal?
Real deal.
Okay.
Real deal. But I'm concerned that he's being set up for failure by an institution that has historically only been talk, has historically, it's looked good on paper, but the support systems that the physician needs.
Yeah.
But that training that he's going to get is going to show him the steps.
We're going to teach.
How he's going to get to the next level.
We're going to teach him how to advocate.
It's going to be really good.
Yeah. How to build a business plan.
Okay. Yes.
Yeah.
I believe in him. And when he was interviewing, he actually came to me and said, what do I need to know about the community?
Good. That's what I want to hear.
So.
Thank you for getting rid of my surprise. I was going, what? I'm going to tell you another state. Oregon? Oregon.
Really?
Oregon's going to have an adult sickle cell medical home for all 5 of them. I mean, Tiffany's had her hand up forever, and then Laura.
Did you? Oh, Kyle did have something as well.
But Tiffany's had her hand up forever.
I just have a comment, I guess, and you kind of summed it up, but basically my question was mostly for the CBOs and for everyone here, was, you know, it sounds like you have to have a relationship with your doctors, and if not, you gotta be like Ray, and you have to.
Turn your mic on.
If not, you have to be.
Over.
Okay. So basically what I was saying is that my question or my comment would be to the CBOs. And basically I was saying is that, you know, it sounds like we need to, well, you guys need to have a relationship with your, like the young lady in the TAM said, you know, get the institutions involved, but also have that relationship with your doctors so that you can openly talk to them and discuss with them, and the nurses too, and talk to them and say, hey, listen, this is what, you know, we have been trained to do as well. And if not, then you got to be like Ray, and you have to, you got to be a Spitfire. So that's what I'm getting out of this.
I agree with you.
That you have to, because that's the only way that you, I mean, we just saw the story with Miss Florence, and she really is a Spitfire. Yeah. So, you know, no is not an answer. And I say that because speaking with Jessica and Brianna, is that right? Yes. Yes. So, and you know, and kind of hearing from some of the other CBOs that may have had some, you know, they really have some barriers, even though they have, you know, things that we don't have, but that relationship is key. And I noticed too that, you know, and I know that VCU has put, you know, is sponsored, but, and Dr. Lopato and Dr. Smith and Shirley, but I would like to see some supportive doctors in here that are with you and that are backing up the CBOs so that we can all come together and say, listen, again, it's all one big message. So not just Dr. Smith putting everything on him, but we have that ability to go back and support all of this and bring it to the table, because like Joan said, you know, I'm a firm believer that, you know, God put us in the right place at the right time. And so this is not information that we have to just sit on. This is critical. And we just saw the message with Nixon. Think about that. Think about the person that we have currently. This is an advantage. I take this as an advantage. You and I've said this even before when me and Dr. Smith had conversations years ago, and I was like, no, this is the best time for sickle cell. And you get, again, like we had the exercise, you got to have faith, you have to have loyalty, and all of those things come together and come into play with this. So with that being said, we cannot just let this sit. This cannot be information that we just take back. Let's be like Ray, let's be like Ms. Florence, and we need to take this information back and we need to share it with our institutions.
Hear, hear. Laura and then Kyle.
You could have let me go before her. That's a really tough thing to follow, and mine's really just a numbers game. So a critical mass of patients. You said when you started the funding there were like 200 patients and you saw a need for the transition program for the grants. Now how about an institution like West Virginia is building and they have a few patients? How to raise the awareness and the level of need in an institution that maybe doesn't have a large population yet? You build it, they will come situation, but how do you get the institutions and the grant process? Is there a tipping point where there's?
Yeah, it's the adult learning model. Adults don't solve problems they don't have. So what Joan told you yesterday in the health belief model applies to medical centers. They have a health belief model too. I don't build a program for a disease that doesn't exist. So you got to have a point of pain in order to really get the attention of your leadership. Now, what West Virginia has is a statewide point of pain. They really need to talk about rural healthcare, spoken hub healthcare, and statewide, how are patients suffering? And you can go to those databases that are available free of charge that Joan talked about yesterday, and you can look at the state discharge database, and you can look at the census data, and I guess West Virginia has a newborn screening program as well. So you can put data together from there, make estimates about what the statewide need is. So rural states like Oregon, you know, have a different challenge than urban states have. Kyle is next. Okay. Kyle, you're going to have to be the last questioner.
That's great. I just had a question. You keep saying partnership, and I was just wondering if you could expand a little more on that.
Sure.
And what that looks like, whether it be, you know, backed by VCU Health, and like what kind of, you know, influence you would have on the CBO. Would GBT be involved? What does that look like? Could you expand a little?
Yes. So write this down. 3 types of relationships to get you funded. Relationship 1, CBO is in the lead. They're the lead agency. That means you're the holder of the bank account. University is your backer. They could be your fiscal intermediary if you set it up that way, but they don't have to be. If you got a 501c3 organization, and you don't worry about going to jail. I keep saying that, but you know what I'm trying to say. Your fiscal ship is in order. You get to hold the money, charge whatever indirect rate you want, et cetera, and you simply hire out people from the university to help you do your scope of work. That's model number one. Model number two is the traditional model. University's in charge of everything. They call on you or push you out, Ray, when they feel like it. They get the money, they hold the money, they give you a scope of work, you do the scope of work for them. Model number three is neither one of you are in charge, but you're both needed for a national project. A national project. That's PCORI. PCORI is using CBOs and are paying CBOs. They're also paying universities, each of which have a scope of work to do Dr. Iffy's project. Right? Am I right? CBOs, y'all getting paid, right? And you have deliverables, right? And they're different from the deliverables of your university. But you're partners. You're supposed to be talking to one another, and they have this word, if I've heard it one time, I've heard it a million, starts with a T and ends with a D. Say it loud. I can't hear you. Triad. I went, wow, triad. Never thought of that one before. So the CBO, the clinic, keep going. Well, actually, it's the patients. It's the patients. In each location. So there, you see the fiscal structure there? And you can have mixtures of those. You could start with one and do the other. It's easy to start with the university in charge, right? All you got to do is say, hey, I want to be your CBO to work with you on such and such a project. Y'all write the grant, call me when you get the money, send me the check. The other way, where you're in charge, is, oh my God, how are we going to write this thing? I don't know. You're up all night. You don't get funded the first time. And you want to quit your job, and you write another grant, and you write another grant, and finally you get funded, and everybody goes, how did you do that? Can you send me your grant? No, don't send them there. You keep your grant. That's hard work. That's proprietary. You did that. We're at a place now where, you know, with a few selected friends, we don't mind sharing. But, okay, all right. Answer your question?
A little bit.
Well, okay, well, ask me the real question then.
I asked, like, what does it look like? So if this is depending on the model we choose, then we can, like, I guess have those further negotiations of, you know, where things move forward.
Yes.
Okay, gotcha.
Yes.
Perfect.
The way it looks is the way you decide.
Gotcha. It's on us. It's on us.
It's on you to decide how it looks.
Gotcha.
And it
Okay.
also depends on where you're applying for the money.
Okay.
So if you're deciding to go to like the NIH, our recommendation would be that your academic center is the lead,
And that's what I was
and you have a
gonna ask, what would
strong
your
PI like Dr. Smith Whitley, being like the person.
She would do that for you. You know that, don't you?
Or Dr. Smith even, like someone who has, so sometimes when, like, if you want to have, like Daniel wants to write like a grant, he has to really, in order to get funded, he has to put Dr. Smith on as the PI. Because Dr. Smith's CV is going to stand out so much greater than
It's just
his.
salesmanship.
It is. But if you go to someone like PCORI, you might be able to do it the other way around.
PCORI demanded that the CBOs get paid separately. They demanded the triads. So give PCORI some dap, because that took some real kahunas.
Yeah. Okay, we need to
All right,
move on.
move on.
So I think we've kind of gone over this indirectly just now. I'm actually not even sure where Dr. Smith left off, but geez, I'm not even sure. Okay, so I think we're just still talking about our medical home team. We've talked enough about that, so I don't want to continue to, go into that. So one of the things that Dr. Smith and everyone in the world wants to know about community health workers and patient navigators is what should be your caseload size. So when we've gone for funding, especially to the hospital, that was a big question. Well, how many people do you think your patient navigators could care for? So let me tell you how we got set up. We went to high leadership, and leadership said, oh, you can't ask for everything. So we came up with a green, yellow, and red system. The green system was, well, you know what? We have about 60 patients right now that we think really could use our intervention. So we asked for little resources. I think we added, it was always the navigators, only 2, because that's who we had at the time from the grant. I believe we did not add the clinical social worker at that piece. And I think we added somebody else. I can't remember who it was. Then we had the yellow lane. And the yellow lane added the clinical social worker piece, added the data analyst. Remember when I told you the other day the data analyst was somebody they said, oh, you really don't need? Well, he was added in there at that point. We were going to add, I think, a clinical psychologist at that point, and then we decided to add the inpatient nurse practitioner. So that was about 150 patients. Still 2 patient navigators, right? Then we decided, well, here's the whole caseload. So we went with the clinical social worker, the psychologist, the inpatient nurse practitioner, the data analyst, my job, everybody, right? So we go in there thinking, they're going to fund that green project, right? So when we went up to the entire caseload of the adult population, we didn't think to add, because we were so afraid, to add any more patient navigators. So they come in, and we're thinking all along as we're having these little mini executive meetings with other people that those people are talking to these people who are in turn talking to these people. And by the time we get in the room, we're thinking these people know who we are. Well, they knew who Dr. Smith was, but they didn't have any idea what we had been doing. So we walk in there, green as can be. And of course, by the time we showed them how wonderful we were, they're like, well, we're going to give you the red column. So we're like, oh, great. We have 450 patients and 2 patient navigators. Where we had 60 patients, we were asking for 2 patient navigators. So you see how we kind of set ourselves up? So it really was kind of like the $1 million question, like, what do you think their caseload size should be? So that's where we said, well, let's focus on these 50 top high utilizers. And then, of course, that you've heard the stories over the last couple days, how that's kind of snowballed and changed and different things like that. But when I was in field work, I always believed to be doing an adequate job, your caseload needed to be manageable. Hospital social workers should not be managing 1,000 patients, or MCOs should not be managing 1,000, that's ridiculous. I think caseloads of 25-ish to 30-ish with a couple crises here and there are reasonable, but I don't think that that is realistic. So I think that's always still the $1 million question. And, I think Marla particularly touched on it. Most of the time now, they're not even working with the people who are on that high utilizer list. Now, last year they did. But this year, it's more like, okay, who's going to be coming on that list? And we're getting ready for, we call them the class of 2018, class of 2019, class of 2020. That's kind of how we're measuring our metrics. So, you really have to juggle that. They do a really good job about it. Getting that third person in there, when Taylor was willing to step in and do some case management, all that was very helpful. So I think if anybody, when you're putting in a proposal, I always say, ask for everything and let them bring you down, instead of going in and being afraid to ask for anything. And then you're getting stuck in the position where you're like, oh, well, that's great that they gave us this money and don't think we weren't appreciative. But if we really knew we were going to get that big, huge red zone, we wouldn't have taken the data analysts out, because they were like, oh my gosh, don't put that position in there. There's no way they're going to fund it. Take your clinical psychologist out of there. And we're like, okay, we didn't know any better. We're listening to these people up here who we think had our backs. So when you're going ahead and you're writing anything for your CHWs, always ask for more positions. And then they're going to probably knock you down a couple. So this was also a lesson learned. I was kind of new to the whole management game when I came in. I was a social worker. I saw all the issues when I was here, but I really didn't know how to put those into practice. I really learned a lot over the last 7 years. So when we got the funding, we were trying to keep costs down because with an NIH grant, you only get so much money. We had to divide it up between us and the EVMS program, and all the whole logistics of it. CHKD had to have their own subcontract. It was all this money going out. So we're like, well, you know what? Let's just hire some hourly patient navigators. You know, they'll work 20 hours a week. We can hire more of them, and we'll be able to do a better job. Well, what do you think the first problem with that was? Think about it.
Patient even goes up when they're not working.
Yes, but guess what happens when you give somebody an hourly position?
Overtime.
No, not necessarily, but yeah, some of it. They don't want to stay. They need health benefits, health benefits, health benefits. Can I say that louder? Health benefits. So when we first hired our first 5 navigators, shoot, I think within 6 months we had gone through about 10. So then I was like, okay, we got to rethink this. So then I said, well, let's take one of those positions and merge it and come up with a full-time navigator, and I think we maintained 2 hourly navigators. Stephanie was one of the hourly navigators who hung in there with us. And we felt, honestly, if you're going to go for it, you need to go for the full-time job. Only for the commitment. You know, you don't get too many people. I mean, I stuck around for 4 years as an hourly. Stephanie, was it 3 years? Daniel was 3.5 years. It was like pulling teeth to get any of these positions full-time. So built in the full-time positions, hopefully it's going to lower your retention rate. And I can't say that loud enough with capital letters. Because I think that people need to feel valued. And you feel valued when somebody says, well, gosh, you've gone to bat enough to get me this job. Hopefully you like it, you want to stay. You know, I'm getting a decent salary. Don't get me wrong, I think you all could be paid a lot more money than you are. That's for another discussion. But I do feel that, you know, you want to feel like you're respected and valued by the people that are working with you. And I feel the best way, unless some people don't want to work full-time, and that's great, but that's not the majority right now in this country because we don't have, you know, standard health care. I also think that it's good to try to recruit through the historical black colleges and the social work programs. And we have not done a good job at doing this. We tried it. We really were not successful. We have two historical black colleges right in our general area. And we originally had posted for positions. We really didn't get what we were looking for. And even when we were looking to hire our clinical social worker, we really did not get a lot of support from our social work department. Oh yeah, we're gonna post a job, we'll make sure, I'm gonna send it to this organization. People say a lot of things, they don't do it. So try to focus on things that are really important. I do believe, at least from, and I can't discriminate against somebody when they're hired, but I do feel from a patient navigator position, I would prefer for that frontline person to try to be African American. I realize I can't always do that. I could get in a lot of trouble that way. But I do think it's really important that you at least make that effort to advertise. I think other staff people can kind of work their way through it, but when you got that frontline person out there.
I like the job description because you can put things like, you know, strong community connections.
Oh, we do all that.
Yeah.
But we cannot put on there what you really would want to put on there. That'd be nice, but believe me, we would get in a lot of trouble. I would really get fired then. So I think if, you know, we really want to, I get a feel for people. So I just recently sat in on nurse practitioner position interviews. I want to see about your attitude when you come into the interview. I've said it 100 times, when you get someone who wants to work with sickle cell patients, that attitude is the most important thing, and you can train anything else that you have going on. And your other colleagues need to respect that. Try not to have barriers to hiring. So we have a bad system on the health, we have 3 systems. Health system, VCU, which is what I am, and MCVP, which is what Taylor and Donna's position are. The healthcare system has very generic job descriptions. You really can't alter those. I had to fight for the longest time to be able to say to them, will you please at least put on there that it's for a sickle cell program? Because once people realized they were applying for sickle cell, they didn't apply unless they really wanted to work with sickle cell patients. That's what I want. I don't want you coming into an interview, deer in the headlights, and not have any idea what you're doing. So, you know, try to make sure your job descriptions are good. Try to work with your human resource department. Ours is getting better. They at least listen to us now. And attitude means everything. You know, you can train somebody, but you can't change their attitude. Like you said, look for community experience. Involve team members. We just recently sat down and interviewed for our third patient navigator, and Taylor, Stephanie, and Marla sat in on the interviews. They have to work with them. Did they like them enough? I might look at something differently, but their opinion is really what values, because if they can't work together, it really doesn't matter what I do. So I do try to involve our team as much as possible sitting in on interviews. Again, I think we said it enough. Passion, willingness to learn, team. Negatives, if you can't be flexible, don't come work. If you've got to clock in at 8 and you're leaving every day at 4:30, but I need you to stay here to do something else, or like this week, we needed people to come here at 7, everybody showed up. I like to try to give you a little, you know, I know you need to go, you got kids at home or whatever. I try to be very aware of that, because at a time when my kids were young, I did not have a supervisor that did that. And I remember that. My kids were sick. They didn't care. They wanted you at work. So I try to have that empathy that, you know, we all have personal and professional lives, but you have to have that willingness to be a little flexible too. We don't ask too much of you most of the time outside of your work hours. We like you to try to be available if we need you to. I said this enough, attitudes, attrition. I think, again, it tries to go to what you can try to figure out when you're interviewing somebody. Dr. Smith loved this analysis, I guess, in the PCORI meeting you all had, about you could have one employee that can tip your entire boat. Do you know what I mean by that? You can have one bad apple. That one bad apple can make everyone else's lives miserable. I have been in that position. It was not fun. Not fun for me at all. I hated coming to work every day. So I understand what it's like when you have somebody who can really make your situations very challenging. So I do try, I try to make sure our team is given the kudos that they deserve, fight for them for their raises, their bonuses. Sometimes it doesn't always work, but you know, we try. I want them to feel like I know the importance of them, and hopefully they feel that way, because Dr. Smith did that for me. So I want to give that back to people that work really hard every day. Again, you know, things we already talked about. And this is Joan. Is there any questions? Okay, thank you. Okay.
I'm just going to review a couple of things we talked about last night, but there are a couple of additions to that. So talk a little bit more about what's going on across the nation in this area. You know, most states, if you're going to do anything, a program out there, you need to be aware of what law is in your area. I think that's pretty a good assumption that we all have, but I'll state it anyway. And most states do not have any laws regarding community health worker role at all, not like those of us that are licensed, you know, nurses and doctors and social workers. So you need to be aware of that, and you probably, and I would highly suggest that you become familiar about what may be happening in your state in this role, because that may impact you, and you don't want to be sitting there and, you know, as you pursue and do a job and do a description and hire somebody, and then your state passes some law that has direct implications. So that's why it's important to have some sense. And that's something we can help you with over these next few months, in that some of these databases and places I've got listed as references where we can find that out. And I think some of you can help us build that kind of database, is that what you may know what's going on in your state. So I'm very willing to work with you on that. And we do have in your booklet what I had found already, and I'm probably already wrong on some of it, but that's something we can be doing to build that information so that we do know what's going on in our various states, because I think that is important. The language in whatever the states that do have laws is totally inconsistent. So there does not appear to be any one, be all, do all. As I mentioned earlier in the last few days, the definition, a lot of people have adopted the Public Health Association definition, and that is in your spiral notebook also. But guess what? We did that in Virginia in 2006 through a legislative study. We officially adopted that definition. Well, 2 years ago, when we put in some legislation, I say we, when the advisory group that I work with put in legislation, and we, Dr. Smith and Shirley and Daniel and I, actually monitored that legislation and actually testified for that legislation. And the first thing the legislators came back and said, this definition is just too wordy, it's just too much, I really don't know what this means, y'all need to pare it down. So now that has been happening over these last 2 years. So what Virginia, through a legislative study, adopted is now probably going to be defunct. So that's going to change. And there will be legislation this year also brought through the advisory group, but by our Department of Health. So we will be monitoring that and see what happens. So see, things change very quickly. As we talked last night, certification varies considerably. Training standards, we mentioned that already, changes significantly. Medicaid payment, we've talked about that, and there just is constant change. And so looking at the state initiatives and looking at reports that various states have done, and 6 states have published reports, and I think I'm probably old on that because I think I discovered one from North Carolina just recently that's not in that count. 10 states have created advisory boards, and 15 of those states have developed a scope of practice. There's 3 states that very clearly state that they require background criminal checks, and that's in their code and in their regulation. But yet there's movement in other states that actually are avoiding that. They do not want that. So it'll be interesting to see. 3 states have authorized certification boards. 6 states require certification renewal. That's a whole nother issue, is once you get certified, do you just stay certified forever, or do you have to renew by doing something? And that's where the continuing education question comes in. And then, I think I mentioned last evening, in that 5 states do have already in place disciplinary and complaint processes. And so that's another piece that if you're going to be working with community health workers / health navigators / patient navigators, you need to be aware of if that process is in place in your state, because obviously the people you're working with need to be aware of that and how you would, as a supervisor, I know in working with Shirley, I know that that would be not a good day if you're getting a call from some regulatory agency and saying, we've had a complaint about Mrs. Jones here, what's going on? And you'll be the one that's going to be creating the documents to have to respond to that. I do understand that because I've worked with nurses, social workers, and dietitians that I was a supervisor for, and that is not a fun day, and I have had to do that. That was a very difficult time to have to, then you have to investigate and do all that. So you want to prevent that if at all possible. So I put this in a little chart of some of the states that is reflecting what I just said, and here again, it's hard to keep this up in that over time things change. So I feel pretty good about this from around 2017 or 18, but for 2019 there may have been things that have happened that it's just hard to know how to go about getting that. I've used a lot the ASTHO website and the National Academy of Programs. There's two really good websites that are in your materials that you can go to that actually staff people do this monitoring and try to keep those up. So there are some resources. We've already talked about, but I thought just out of reference, let's remember some of the laws that we've talked about in this training. You need to be very aware of those laws, the Civil Rights Act, the HIPAA, obviously we talked a lot about. I can't remember what day it was it just yesterday, I think? The 42 CFR and the FERPA, the Family Educational Rights. These are laws that you should become very familiar with. And hopefully you have in your locality a resource to help you with finding those laws, interpreting those laws. You don't necessarily have to have a lawyer on staff, okay? Another law that we haven't mentioned that I thought I'd mention very briefly is the Americans with Disabilities Act. I have a feeling some of you could probably educate me because you've dealt with this maybe through family members or children or whatever. Not that to say that our sickle cell patients are disabled, but there are titles, the Title 1, 2, 3, 4, and 5. And as an employer, which some of you may be, supervisor, or you may have family. So you need to be aware that there are rights of persons with disabilities. And disabilities is very broadly defined in this law. So as an employer, I see some heads shaking, if someone comes to you and let's say they have sickle cell, but they're doing very well and they look pretty healthy or whatever, but as an employer, they come to you and say, you know, I cannot stand for 6 hours straight. I can't work the cash register. I need breaks. Well, guess what? An employer under this Americans with Disability must accommodate, all right? And so when I'm hearing horror stories that people from a work situation are suffering from maybe termination because they're not doing the job, well, I hate to tell you, but that's against the law. And we all need to be aware of that. So the website for Americans with Disabilities Act is a wonderful resource, and it's very clearly stated. So like the Title I is about employment, what I was just referring to. Title II has to do with qualifications for programs, and this gets more into if you're running a program, what do you have to make sure you have there and available to protect the rights of folks with disabilities. Public accommodations, we're all very familiar with that law, correct? It has to do with public access, being able to access restaurants, public places, institutions. I'm appalled, it wasn't that long ago, the dentist I go to, there's steps and there was no way to get into this dental office. And it really came home to me because I have a sister who, with health issues, is wheelchair bound now. And I'm very sensitive to things. And here she'd been in the hospital and she was trying to get to the dentist, and her dentist, she had no way of getting into her dentist's office. And I said, oh, well, let me see. Well, my dentist didn't have it either. So she had to go find another dentist because she had no way of getting into her dentist. Now, people have this grandfather clause, but I'm sorry, if you're in the business of serving the public, I think it beholds you to do something. We have restaurants in Carytown and around the city that are in old buildings, and they don't have bathrooms that are accessible to folks that need help. So we need to be aware of those kind of laws, not only to advocate for our patients who may need help, but also if we happen to be running a program, then you need to be aware of those laws so you can make sure that you are taking the account. And then Title IV is all about the phone and internet, and of course those regulations are, we probably need to work on those because there's so much that's happened that some of these regulations may not be as strong as they need to be. So we have to watch that. And then Title V is all about the insurance and who you can insure and who you can't discriminate against, and a lot of things that I don't deal with directly, obviously, but it has to do with the relationships with other laws, like insurance laws and the relationship to disability and to access. So these, I just mentioned this as to, and I'm certainly not a lawyer, but try to become familiar with these. All right. Yes.
On the employment part,
yeah.
you actually have to be a designated person with disabilities to make that argument. I cannot stand up for a certain amount of time.
Say that again. I want to make sure we're hearing. The mic is somewhere. Oh, here it is. Sorry.
Yeah, the question was around, did the person or a person just in general have to be designated as disabled to be able to say to an employer, I can't stand up for a certain amount of time, you know?
No. We think that's true, and it's not. Yeah. Thank you, Dr. Smith.
Between ADA and FMLA, your note from your physician with specific designations of what let's talk about sickle cell, of what the limitation is. So my note would say patient with sickle cell disease cannot stand extremes of cold or extremes of heat. Therefore, they can have a space heater. Or cannot sit for longer than 2-hour period. They can't hold their urine, need to have bathroom breaks. Or need to be transferred to a different job. You've got them in the freezer room in the packing plant, and they need to be in another room. Now, I'm not telling you it's all smooth. But the law says that they have to accommodate.
And also, I think when you're in we're in the state system, it's a little different in private sector. But in our state system, there's a fairly rigorous survey that the employee fills out when you get hired. And there's very specific, so like whether you lift and all about your job. And if you are hired, once you're hired, you're protected. And so the employer, if something changes and you cannot perform the job, then there has to be an accommodation that's reasonable. And that's where things it gets really blurry there. Because, you know, if you are, say, a nurse and you become blind, well, we have to accommodate that, but how do you go take care of patients and see monitors and all of that? So it gets, and I've had to deal with that in nursing school. I had a patient that was non-hearing, a student. It's like, how is she going to become a nurse? We had to accommodate that student for 3 years, and she graduated and she became a nurse. But then she was able to do nursing in a very specific job that did not involve acute care. So that was a very painful 3 years, I can tell you, trying to accommodate for that. Yes, Barla.
Oh, I'm sorry, I was just gonna say really quick. I have written letters for my patients for employment as well as for schooling, as you all had mentioned. I have my students who are about to go into college make sure that they touch base with their guidance counselor at whichever college or university they're at so that they can have a letter of accommodations on file so that they will be exempt from taking tests, to be able to retake a test or take a test at a later date. Right. Let it be known that they might be hospitalized for several days, so on and so forth.
Yes. Marla, would you just, okay. Yes. And I don't have all the answers. I'm not a lawyer and I'm not an expert in it, but I want to raise it is that we need to be questioning that, and whether we're serving our sickle cell patients that we want to make sure are being protected under this law, but we also may be employers, and we need to be aware. Yes, Ray.
I have a patient that was going through some challenges with his job, and he works for a very big retailer that's in every city and every inner city. But what they and they source out so much of their HR, and especially the FMLA, and so by the time you fill out your papers, send in the letter from the doctor, the person who you're talking to is so disconnected from your actual job. But once you mention, and this is what I ultimately had to do, I had went around with this woman so many times, and I made sure the patient was on the phone with me so that he could hear how the conversation went. But the moment I began to mention his rights under the Americans with Disabilities Act, ultimately we continued to haggle, not as strongly, but at the end of the day he got everything that was on that list, because I said this is borderline illegal at this point. So we can take this a step further, or we can solve this in this conversation. So sometimes you have to leverage the fact that there are laws to protect them, not in what you're trying to do here. So
correct. Thank you, Ray. So we talked a little bit last night about how our CHW is paid, and I think we've kind of got that. Grants is really the main way right now, but hopefully what the experience that the team was going over this morning can show you that as soon as you get that grant, start thinking about the next one, and then start figuring out ways to, the word that I hear used is institutionalize your program. And some of the grants that have been done with community health workers did not do a good job of that. And I've heard this many times. A hospital went out and got a grant to do some community health workers or health coaches or whatever, and for 3 years they did fine, and as soon as they closed the doors, then the community health workers were released, and there is no. And I've heard that from community health workers across this state more than once. So if you're going to get a grant, that's great, but start planning for what happens when the grant is over. Medicaid is, why is Medicaid so important? Why I keep talking about it? Medicaid is our major player when it comes to not only our elderly folks, but a lot of our high-risk vulnerable populations. So therefore, and a lot of times what Medicaid does kind of drives the train as to what other people are going to come along and do. In many of the states, including our own, that's part of what we've been working on is our Medicaid folks, because we know that because as the monies come from the feds, it comes to the state, and I hope you probably all very much are aware of that every state must write their state plan, all right? Is everybody aware of that? I think some people. Money doesn't come directly from CMS to pay the Medicaid bills. It comes to your state Medicaid office, and they write a plan every year, and in fact, this is about, I think it gets due right about now. And that plan they put in, it gets approved, and then that's how money flows into the state and then pays for. I'll try to stay apolitical, but it'll be hard. Those states that hopped on the Affordable Care Act.
Go back. Not 100% of the money comes from the state.
Oh, okay, thank you. Yes, you're right. The state.
Every dollar the state spends on their state Medicaid program, the Fed will match a dollar. So it's really state/federal.
Right.
And it's
Thank you.
organized by and half paid for by the state. And the enthusiasm with which the state puts money into it is matched by the enthusiasm of the federal government, dollar for dollar. Now you're set up to talk about.
Thank you. I missed it. Now, you'll hear about waivers that a state can write into their plan a waiver, like an exception. And those waivers can be matched with a very lucrative ratio.
Yes.
The example I'm very aware of is the family planning pieces of Medicaid, because see, we serve high-risk indigent women, okay, in Medicaid. During pregnancy, and postpartum. And for every dollar the state of Virginia put in, based on their state plan, we got $3 of federal dollars drawing down. Okay, in the Affordable Care Act, I think it was a 1-to-3 ratio, wasn't it? I don't really.
No,
Affordable Care, was it a 1-to-1?
It was 1-to-1, but it was raising the qualification level.
Yeah.
That's the first part.
So you could bring more people in.
So you can bring more people in.
Yeah.
So you know, it was 100, instead of 120% of poverty, it went up to
150,
160.
yeah, 180 or something.
Yeah, whatever the state wanted. It's again,
Right.
how enthusiastic do you want to be?
Right.
If you want to take to the 180% of poverty level, okay, we'll pay you those
We'll pay you, but you got to pay the matching dollars. Yeah. So the states that participated in the Affordable Care Act expanded their services, and the last data I just saw not too long ago, because it's been long enough, that the states that participated in the expansion are now seeing some very positive results. They're getting more people into health care, which you're saying, well, that's going to cost more money, but no. They're having a reduction in hospitalizations, reduction in length of stay in hospitals. More people are getting vaccinated, more people are getting flu shots. So you're seeing improvement, and some of the outcome is things like the hypertension and heart disease issues have abated. Virginia, we just did ours last year. So we're not going to have the data to show anything. And of course, that's going to be an issue as time goes on, what states, you know, and that's compared to the states that chose not to do the expansion. So the states that did are doing much better than the states that did not, because that was the whole intention of the Affordable Care Act, was to expand.
What leverage do they have to be fighting it so hard? I mean, obviously we know the leader of the administration.
Right, right.
But if you're not doing anything on a grassroots level to help people to understand so that they're voting accordingly,
Yeah.
right? I just...
Every state's different, right?
Yeah. And
Minnesota, let's just be honest, Minnesota could afford to do it.
yeah.
Well, I mean, the devil's in the details, but okay.
They could afford to do it. There was a low risk for them. Louisiana?
Yeah.
That's a high risk.
Right. I don't, did Louisiana? I don't know.
Now, it's a high potential gain,
Right.
but it's a high risk.
Yeah. If you've only got $500 to put in it, then that's what you got. That's what the pie is. So,
Taxpayers are poor.
right.
The costs are high, and Louisiana is saying, "Oh, we're just going to
Right.
be bad."
Right.
I'm being brutal here.
I know.
That's their logic.
Right.
Wrong, but it's their logic.
But,
Alabama,
yeah.
Mississippi.
Yeah, I don't think any of those. I don't know who would.
And we have to actually go we have to go to Senator Gerald Love to help pass legislation for better Medicaid reimbursement for
Okay.
sickle cell
Y'all-
services in
yeah.
the state of Tennessee.
Right, right. It can get very political, absolutely. The Medicaid reimbursement, I think you probably do all realize that from the national level, there's not a direct, in other words, Dr. Smith doesn't get a direct payment for a Medicaid patient, all right, from the national. It's all based on the state plan. So I've heard people, well, being that I'm around this group, you know, we got to go to the Medicaid, you know, up at CMS, and we got to do, and I'm like, no, where you need to go is to your state, because if you can get into your state plan, then you got it. Because yes, the feds have up to this point supported the role of the community health worker. They changed the labor, we've got a definition in there, and there's actually code numbers in there. But it doesn't matter if you're in a state that's not willing to put the community health worker into your state plan. All right? There's a question back there, and I don't know where the... Oh, there it is. Thank you. Would you take it back? Yeah, push the button.
Hi.
Morning.
This question may be jumping ahead, but I've noticed in Virginia recently that with the Medicaid expansion and the different healthcare providers, and that they are now their case managers are doing a little bit more outreach, and I don't know if that's coming under the CHW part of things, because I work in pediatrics, and I've gotten a lot of calls and a lot of case management follow-up to say, we've looked at this person's record, we saw that they haven't picked up their meds. Are you guys kind of following it? And we're like, yeah. And it's kind of like a double place, and we're like, so you're calling me and asking me the same thing that I already know, and but you're billing for, I'm sure you're billing under a case management or something note in the system of Medicaid, so but you're talking to me and not actually talking to the patient, so how is that direct care?
Right. Yeah.
Okay.
You're on task.
Suddenly, remember what I said?
Yeah.
So guess what? These guys are seeing value-based payment as their modus operandi now.
Right.
You got your dollar in January. Don't spend it all in one place. Go get that case manager. Go find that high-utilizing patient and tap it down. Call VCU, call EMS, do what you got to do. Save us some money. And so that's why it's happening. It's good. You couldn't have said anything better.
Yes.
As soon as the switch was flipped, and we had expansion, boom.
And just to piggyback off for what you said, I had someone call me from Magellan, and they wanted to do a 3-way call with the patient to do like a treatment plan.
Oh, wow.
And they have called me looking for the patient.
Yeah. Okay. Just to add to that, you're right on target. Somewhere in the last 6-9 months, the big CMS at the federal level has redefined what is allowable in a state plan. And up till now, a lot of what's from CMS has been the term medically necessary, all right? And that was much more narrowly defined. They've now broadened that scope and said some of these other activities, interventions that address the social determinants of health are now allowable. So that's been a boon for the kind of services we're doing. So in other words, if your patient is living at home and has a hard time, we all know about transportation issues, and I'm sure all of you have been dealing with that a lot. But things like they're not eating adequately. So now, in that state plan, they're now allowed to put in there that they can provide supportive nutrition services. Now, it's going to take time for some of all of this to trickle down, because this just kind of happened in the last few months, okay? But that's a boon for what we're trying to do, because we already go, duh, we know that, okay? But it's taken a long time for that to trickle down from the federal level. But where you really get a hold of those dollars is through your own state and their state plan. And as I said, it's like a yearly thing. So if you go in April, well, you know, I don't know, you may be too late, because they've already it's during the summer that the states are putting together their state plans. And I know that because I used to spend time in the summer working with Medicaid because I was involved in the family planning waiver and the prenatal care part with Medicaid. And luckily, over time, our office had a wonderful working relationship with our counterparts over at our state Medicaid office. So they would actually call us and say, come over here, we're working on our state plan, help us, because these are policy people. They're not necessarily nurses and social workers and doctors. So we could go in and talk about, oh, well, you know, you need to include that in prenatal care. That's standard of care. How come you're not including that? So it's wonderful we had that relationship, but not all states maybe have that, but that's worked. And then the other piece, just to this is another way community health workers can get funded, is that every state has a certain amount of administrative funds, and in those funds, a state can decide, they have to get permission from the feds, but it's something, it's different than the actual reimbursement dollars, and they may actually fund a pilot or a program, a demonstration project, okay? And that's how, well, the program I worked with on working with pregnant teenagers, we were using the Medicaid administrative pool of funds to demonstrate the effectiveness of that program. And we went for 30 years before we had to then do something different. That was interesting. Yeah, we demonstrated for 30 years. Because everybody bought into it, and we were having good results, and nobody questioned us. And then the feds came in and said, "What is this you're doing?" And we had to do some work on that. But anyway.
I'd like to address Lakia. Our next support group meeting, we're going to have a community relations representative from Virginia Medicaid Plan. Oh. She is with Anthem's Health Keeper Plus, and that's on October the 21st at EVMS. So she may be able to give you some additional information as well. Okay.
Exactly what they do, but the point I was trying to make is to distinguish between community health workers, and if you already have a case manager, what the insurance will say that they are technically doing
it.
What community health workers are doing.
Excellent.
And there's a way to phase it out from being reimbursed.
Right. Right.
They're saying that
Excellent point. Excellent point. We all need to be aware of that. And I know one of the issues that I've dealt with over the years is, let's say the HMO that's doing the Medicaid, they decide, oh, we're doing that. We're doing that. And you know what they're doing? They're making a few phone calls. And then they think they're doing it. So that's an excellent point, and that's really a learning curve, and that's a challenge that we need to be active trying to address. Yes?
So, yes, Lakia is absolutely correct. But what I would recommend is to go to the DMAS, the Department of Medical Assistance Services.
Right.
They have town hall meetings, and they're free.
Yeah.
And they usually have them at the hospitals.
Yeah.
And you get to meet and the governor and all of the those that are in charge of the that make the decisions for your state. Also, you also get to meet and speak with the MCOs, so Anthem, Aetna, all of them. Yes, but that would be an opportunity for you all to go and present what we are discussing as healthcare workers to the governor of your state, and that's what we have done. And they have it like I said, open enrollment is coming up, and then and especially with if there's an expansion in your state. But that's what we've done every year. Well, for the past couple of years, to go and speak with the commissioner, I believe, and the behavioral health specialist, and all that good stuff. And you get to speak with them one-on-one, network, and the doctor for the state. And then you can present that information to your state and tell them that listen, you need to write this in as a community health worker, and let them know and help distinguish between the care coordinator, because that, like she said, that's what they're doing. They're putting everything on a care coordinator, and they're eliminating some of the other the middleman. So yes, that's what they want to do. They want to try to save, especially the MCOs.
Yeah. Good point. Thank you very much. Where am I? Right. Okay, so I think we all understand that Medicaid is an important group for us. It's not the only. All right, and we've talked around this, but I don't know whether we've ever shown the triangle, but remember the triple aim? And we've been talking about this for the last 3-4 days now, right? But I like the image there. And it's all about controlling cost, isn't it? But hopefully we're improving. There was a project out of the national DMAS, the Delivery System Reform Incentive Payment Program, better known as DSRIP, And not all states do this. Our state, I think, had a wonderful plan, but never got funded. Never got funded. Some of the states, there's a report that came out, I think New York and Texas were two of the first states, and they've been looking at their data, and there is a report available you can read. And they've had some pretty good results, but it's not as strong as I think some people were hoping.
Texas got a sickle cell clinic out of that.
But they did get okay, great.
Houston's sickle cell clinic.
Yeah.
God, that website is wonderful.
Wonderful.
We lusted after that website.
Yeah.
It's adult plus pediatric.
Wow.
Started from scratch, ground up, all funded by that program right there.
Yeah.
Doctors, nurses, social workers, community health workers, dental.
Yes.
Oh my God.
Oh my God. Yeah.
And it's affiliated with the University of Texas in Houston. And they rapidly, because they're in Houston, they rapidly ramped up their number of patients.
Oh yeah.
Rapidly.
They had a good pool to go from.
They had a good pool to pull from right there in Houston. They have competition in Houston, if you want to call it that, competition, but they're going to be the biggest clinic in Houston in a matter of a year or two, probably.
This is a 3 to 5 year, and I believe we're in like year 4. Being that we don't have one, I don't have intimate knowledge, but this is a grant. So what will happen to this, we don't know. Hopefully they will be able to institutionalize their sickle cell and will continue, but that's left. Oh, the state plan I mentioned earlier. This is what I was talking about. In Medicare has expanded their definition to allow insurers extras, they call it extras, on top of traditional Medicare offers. And one of the good examples is like Meals on Wheels being delivered to the home, but a lot of other different expansion kinds of services. Now, I'm going to pick on Minnesota. Minnesota is one of the first states that moved forward on the community health worker, but in a very formal way. They have to become certified. There's minimum, from what I understand, what I read, minimums of education through the community college system, and then they become certified by Medicaid and then get direct reimbursement. Ray, you're our expert from Minnesota, so.
Again, I'll just say the devil's in the details. I think that
Yep.
you can write the legislation, but then how it's interpreted is so individualized. I can say that I am only aware of one institution that actually utilizes
right.
CHWs, and even then, it's now you have to still fund it because there is still a lot of resistance to the role itself. So in many cases, even though they are functioning like a CHW, they will have different titles, which then changes the education requirements. So they worked around. I think that it's a great start, right?
Yeah.
And
it's a model.
Honor the start of it, but I also don't think that I don't know that they brought the right people to the table to create the skeleton even of it, which then creates an uphill battle for those who are actually doing the work to try to live within that boxy, quite boxy model.
Right. In fact, I'm just going to say this because in some of my dialoguing with my community health worker colleagues here in Virginia, and we've talked about that, is that now there's some of the community health workers in Minnesota in some meetings and webinars have said, you know what, you may not want to go that route until you build a workforce that you may, in other words, I'm hearing that we're better in Virginia that we haven't done some of this, because this way we can build the workforce of the real people that are doing the real work, and then they can go to the legislators and whatever, and we'll get a better product. Even though I think it was very exciting that Minnesota has done that, but there's pros and cons to going that route.
Yeah, and I would say this, I mean, even though I use the analogy of being at the table quite often, I've actually moved more towards not only, I don't want to just be at the table, I want to be the one writing the menu, because by the time I get to the table, I'm probably going to switch a whole lot of things up that were never even thought about.
Right.
And so if you're not even before the table is set, we need to be having those other conversations as well.
So see, sometimes you're here and maybe a lot hasn't happened, but you're at a point that you can really make things happen in a better way. So indirect reimbursement is what we've already talked about. Is you're part of the medical team, and it's the value-based, it's the payment is coming through in relationship to that care. And at this point, if you can deliver quality care at a reasonable cost, then that's what the whole reimbursement issue is all about these days. So I guess the bottom line is you've got several ways to finance this. And as we can talk and talk further, a lot's going to depend on what's going in your state. Your steps in doing this, Dr. Smith and Shirley have already kind of gone over some of this, but in the financing piece, educate, educate, educate. And you take every opportunity to educate. You know, you might be at some fundraiser and you've got a couple of legislators there or a legislator, you know, that's your time to get that ear. You know, so take opportunities. Relate the need. I think you've heard this over and over. We've got to relate the need. And then you'll hear the term write a business plan or a business, you've got to make the business case. I mean, that's what we've talked about. And there's actually wonderful models out there of writing a business plan, and that's how we have to kind of think about this. And that's essentially what you guys did. You wrote a business plan and went to the VCU part that was that. Piloting is important, so sometimes you just got to suck it up and make it happen. So remember, you gave the perfect example in that you've got to generate some data, and sometimes you've got to figure out a way to suck it up and do it. And we were lucky you were able to kind of squeeze out, even though the feds may not need to hear that. But through that resource, you were able to do some of that work. And then you've got to bring your program to scale. Start small. Shirley made a big point of that. Start small. Start reasonable. You cannot serve everybody. And I think in today's world, like West Virginia, I'm sitting there thinking about you, and I have connection to West Virginia, and I be there, and it is pretty rural, y'all. We're going to have to get creative, because if you only have, how many patients you guys think you've got?
We have no idea, because we've only had 3 clinics,
Right.
and there's been like 4 patients.
Right. So you've got to think creatively, number one, how to even get the data that you need to find out what your pool of patients is. And then we've got to be creative about using our technology. You know, we've really got to get out of the building mortar and stuff. We're going to have to start, how can we work with the telehealth? I mean, that's out there. Maybe that's going to be the route you're going to have to take, because you got a big state out there and it's really rural. You got lots of mountains, and I'm not sure that your satellite's even going to get across the mountain. I mean, I lose my Cirrus when I go driving into West Virginia. So we're just going to have to really get out of the box, and hopefully through some contacts that you're learning and getting here, we can maybe help you think about out of the box. It's all of us. Right. And then, of course, sharing the results. And I'm hoping that's where some of what we're doing is going to be important, is that hearing from Ray has been wonderful. Hearing from North Carolina has been wonderful. Sharing this information is going to empower us to do what we need to do. So I just asked, you need to find out what's going on in your state. Many of you seem to be already well tuned in. If you're not, hopefully some of what you've learned in the last few days can incite you to go on and find out some things and answer some of those questions. What policymakers or persons are you strategically targeting? And we were talking last night about even here at Shirley and Laura, we were like, we need a champion. We need a champion. How we're going to find a champion, all right? So we need to be thinking of those kinds of things and use whatever opportunity. And every mechanism that we have, we got to tap into. Where are we on time? I'm over here. I'm good. Okay. Do we have time for a few other comments, questions, if there are any? Do we all understand? I know something that goes on here in our state, and it may be slightly different in your state, and you need to know that. What people don't understand sometimes, and I've worked with this with our CBOs, is that in Virginia, all federal dollars come to Virginia, to the Virginia government, all right? And then our General Assembly allocates those dollars. So when there's dollars in the state that we collect through our taxes, and then we, of course, our dollars go on up to the feds, but then the dollars that stay at our state, every dollar has to be allocated through our General Assembly. And I think that's true in all states. So therefore, if you think you're going to get, as a small CBO, the likelihood of you getting direct dollars from the state, as the least organized you are, is you're going to have the least likelihood to get them. You've got to have, as Dr. Smith was talking about, that fiscal agent. And if you're really a small little operation, ma and pop, it's going to be difficult. So we have to be accountable to everything. And I think that's where sometimes our folks, I've had that with a lot of different issues around the state. They want to do all this stuff, and they think the state can just give them dollars to do it. It doesn't quite work that way. Yes?
So you've seen the video about the history of Virginia with regard to the advocacy and support that they've gotten. The people in that video are still in the fight. And that's a good thing, but it's also a bad thing. Okay. Because some of their ideas and the leadership that we currently work with, all the board members have been there for 20 plus years. Oh. The support that we get is pretty much, that's not going to work.
That's right.
No, that's the support. Oh, that's not going to work. Yeah. You know, the things that we, try to come up with. So in that family, I'm going to call it a family because, you argue in families, bringing some of the information that we've gotten here to our group, I think may be able to push that scale one way or another. But we also have other organizations that are around the state that are doing their own thing too. Yeah. So when you made the statement about the mom and pop thing, it kind of perked my ears up because the mom and pop people and pop are the passionate ones. We want to go out there, we want to change the world. But the grandparents, the infrastructure that's currently there is jaded.
Yeah.
And the population that we support, some have a little, some negativity. So my not a question, but it's a
I'm hearing.
It's a question. What do we do? What you got?
What we doing?
All right, Laura.
Oh, okay.
Come on now. Don't think this is out of school. What do you want, Laura?
So we do, GBT, so GBT does have a grant program for community engagement and partnership. So thank you for letting me circle back to this because there are buckets. Right now we are a company of 250 employees with no revenue stream. We don't have an approved product. So we solely are focused on developing programs and partnerships within sickle cell. So we need you to help us get there. Yes, we have a product under FDA review, and we are hopeful for that, if it's the right thing for the patient. And now, again, it's a for-profit company, so at the end of the day, yes, programs that we invest in, we want to make sure that there's an output that leads to either, you know, improved quality of life, patient care, things like that. But there is a huge recognition for the community-based programs and for the mom and pops, because you guys are the champions. And we recognize that without that relationship and without getting there on every level, there's no way we can move this path forward. So there is a grant process. If you guys want my email, jot it down. Some of you have given a card. It's lpridgen, Pridgen, @gbt.com. lpridgen@gbt.com. And I can send you the link for that community base. We support things. We don't support camps, apparently. I'm just learning. I don't know why. I think that sounds fun. I want to go to camp. But we do things like a barbecue. I heard, it's all over. So I am the medical person living in North Carolina, and I cover Virginia, Tennessee, and West Virginia. But there are individuals such as myself and better in other areas. But it doesn't matter. It's independent of us. This goes into the corporate review. There's a lady named Jean Laboda that heads the community-based organization and partnership group with GBT, and it's a grant review system. We encourage, it's separate from academic institutions, talking about the pillars of how to get funding. This is solely community-based. In fact, if you are affiliated with an academic institution, you're triaged in a different way. So send me an email, I'll send you the link. And yeah, so thanks for giving me the chance to.
Yeah, thanks, Laura.
Yeah.
Start. I mean,
Yeah.
I can say this, we're in a family. Until we speak with one voice,
Yes.
nobody's going to listen. Politicians aren't going to listen.
That's right.
The president of her company is looking for one voice. The president of any pharmaceutical company that has a product is not wanting to talk to 50 mom and pops. They're wanting to talk to one voice. SCDAA purports to be that voice, but the reality is there are people who know the legacy of SCDAA, and so they said, just like on a local level, they're not listening to us. They went off and they did mom and pops. And now all those mom and pops have an organization called the Coalition, or what's it called? Consortium.
Okay.
I get it right. But now I'm hearing within the consortium there's this political infighting. So one voice is the answer. I can't make it happen, but God knows if it were to happen, it would significantly improve the funding stream, and all boats would rise. All boats would rise, because suddenly Novartis, Global Blood, Bluebird Bio, these are billion-dollar, billions, did I mention billion? Billion-dollar companies. Funding you would not empty the lint out of their pocket.
Right.
So that's why I said, do you realize what you have here? Do you realize the power in this room? You've got it, but you got to speak with one voice. And I can't do that for you.
Right.
I'm not a CBO. I can help you. I can help you write your grants. I can throw you some words and maybe a fiscal or a budget or a analytic person to help you with the dollars and the strategic planning and the organizational plan. I can do all that, but I can't do the work. You have to do the work. And the work is for your patients, first of all. I knew Laura was going to say for our patients first. I knew she was going to say that. That's like in her DNA to say it's for our patients first. But it is for profits too. And for us, it's for our patients, and it's for our feeling like when we die, somebody can put something on our gravestone. Thank you. I mean, we're all wanting that. This is one of Maslow's hierarchies, right? I want to feel good about what I did. So let's be honest with ourselves. We all want our lives to count for something and make an impact. There's nothing wrong with that.
Yeah. You had a... No, you sure?
Oh,
Shamari. And I know in looking for grant money, it is a challenge, but there are smaller foundations and, other groups around, and it's a matter of just piquing their interest, and sometimes it takes more than once. And I like what you were saying in that, getting on agendas. It's not just getting on a legislator agenda or the Medicaid agenda, but sometimes getting on an agenda for some of your local foundations and groups. And don't go expecting a lot. Don't go with the big ask either. This is one time you don't want to go with the big ask. You want to go to educate, raise awareness. Then maybe in another year you go to ask, but in some of the projects around Virginia have been funded by some of these private foundations that have gotten the message. They're not sickle cell, but they certainly are understanding chronic disease and the impact it's having on communities. And so we'll see. Shamari? Yeah.
This is in response to Mr. Dew's question. I think, as we have learned in this training, is that you have to start small. So I think one of the great things that I know that the CBOs are getting ready to do is that meeting where you're bringing all of the CBOs together. So I think from having that meeting, you start very small. And I understand the pushback that you are getting from the organizations. But I think that is at least a start that you are having with those organizations. You're bringing everyone together to be on that same front of having that one voice in Virginia. This is what we would like our organizations to look like. You have a uniform voice across Virginia, and I think the start is by having that meeting in November when you're bringing everyone together. So just start small, and eventually I think it'll come.
So I was having this conversation earlier this week, and one of the things that in my work, what I didn't know is when I was growing up, even in Minnesota, I had this fascination with the Black Panthers. I didn't really know what was drawing me to them, but there was something about them that stood out as different. And regardless to the narrative that has been given about the work of the Black Panthers, their impact on newborn screening is yet to be truly told in almost all of the stories that I hear. One thing that I think they did amazingly is their 10-point program. And they didn't vary from that 10-point program. And I strongly believe that if the sickle cell agenda were centered around a 10-point program, and it doesn't have to be 10, maybe it's 5 points, and that every organization or every advocacy effort and every comprehensive clinic, whatever the case is, the focus is around the however many points so that we can continue to have a unified voice, then I believe that we can be better heard, because the term divide and conquer is there for a reason. And it feels as if that the resistance, the opposition seems to look for the cracks and then use those against us. And we have to understand that ultimately our agenda should be the same. And hopefully, that can carry us to the next generation and the next generation and the next generation.
Thank you. I have a, I guess, question. We were supposed to have a break, but we really aren't having goodies. So if we could just, people can take care of their personal needs, but if you'd like to move on and bring Shirley up and keep moving, and then we can have lunch, and that we may be able to get you guys out a little early. I love the discussion, but I know we're beginning. Is that something you want to do? Yes? Yes? Shirley?
You know, I'm a talker, but I got to tell you, I'm tired of talking. So, my husband would be thrilled. So, I'm going to kind of glow. So, I guess a question that I have is anybody here looking to do, well, some of them stepped out, so I'm just going to start. But the next session after this, I do think it's important. It's on burnout and compassion fatigue. So, I want to be able to brush over this, maybe get our lunch, get started a little bit earlier, and then try to get you all out of here, because some people are flying, but most of you are trained and driving, if I'm not mistaken. Okay, so basically I'm just going to go through this really quick, but if you're looking to build a medical home, you need a couple key component people. Obviously, you need a medical director, and there's all the responsibilities listed there, which is probably only 1/3 of what Dr. Smith actually does every day. You also need somebody to kind of do the nitty-gritty work. You know, someone who's going to go to bat for you and in turn has to deal with all the administrators above the team. These are, again, just some of the things that we do every day. I've said it 100 times, you need somebody to be able to run your numbers. The only thing that's going to keep you funded is when someone knows how much money they're saving, how many days you're keeping people out of the hospital, how you're handling them in the emergency room. I hate to say it, but it does really kind of drive the ship. This is a really expanded team since we actually started, but we have Dr. Smith, you know, who kind of oversees all of us, and then we'll have Dr. Lopato, who oversees the infusion piece once that gets started, and then my role kind of who reports to me structurally, and our grad psychology student's no longer there, but he was kind of out there in no man's land. I went over this earlier, but these were some of the key functions that we put in the impact that we thought we would be able to have when we presented to leadership. You don't have to copy this exactly like this, but it is something that is important because, of course, they're going to want to know how you're going to get to where you say you're going to get in order to achieve the overall outcome metrics that you're going to be reporting to them. Again, in order to really get the metrics that you need, the staff really are the ones who are going to drive that show, and they're going to do that by documentation. So we went over a lot of those documents yesterday. You don't have to use them verbatim. You don't have to use them at all. But just know that however you do it, make sure that it's easy for your data person to extract that data, put it in wonderful charts with, you know, graphics and little cylinders and all the colorful tools that make it look like it works. And whatever you do, make sure your numbers add up, because you're going to have somebody above you who thinks they know more than you do. And I will tell you this little quick story. When we were putting this proposal together, Daniel ran our numbers.
He did.
We were told his numbers were wrong. He could possibly not know how we got this to this place, A to Z, whatever. Long story short, Daniel was right and they were all wrong. So, over time, I've tried to figure out the best way to be a functional supervisor without being a micromanager, because I really don't like to be micromanaged, so I don't like to have to micromanage other people. But we've gone now where we actually try to meet at least bi-weekly as a team, and since our team is changing, that may kind of move around a little bit, but we have some processes in place. And then recently, I did think, even though there's 3 with me, 4 people, it was nice to have a little powwow every morning just to kind of recap everything. I do try to keep my door open for staff because they do come if they need something or want to tell me something. That's fine. I do periodic note reviews. I'll just go in, kind of see if they're meeting their metrics and kind of making sure they're documenting, and they do a great job documenting. They're very thorough. That's really nice. I actually miss going out, so sometimes I like to ask if I could go with them, but most of the time they have it under control. But if they do need something, I don't have a problem ever leaving my office and going out there because I think that's important. Again, you have to balance personalities and styles of intervention. Everybody's different. Everybody has their way, and as long as it works, and they do their job, that's fine. And of course, continue the flow of the team, making sure that you're available to be listening to their issues and trying to resolve them and still maintain the balance of the team. So Joan is actually the guru on the C3 project, but we put together what we want to have as far as job descriptions. We're trying to look at maintaining the core competencies that are really been identified for community health workers. And we also want to make sure that their knowledge, skills, and abilities, along with the attitudes, which I still put up there as I think almost the #1 thing, helps drive that job description and also helps you to be able to interview the right people. So like in my case, if somebody applies on the VCU side, I'm able to review all those applicants and be able to select candidates that we want to have for interviews. But on this new role, so Marla and Stephanie are on the VCU side, but the new person that's coming in is going to be on the health system side, and someone else uses this computerized metric system to figure out who you should be able to interview. I don't like that at all. But it's what you only have to deal with. So you try to make that job description, like I think Ray was saying earlier, that you try to make sure that job description can actually match that, but then they have these generic job descriptions, so you're kind of stuck. In fact, kind of a sidebar story, the applicants that we just interviewed for this position, I think we interviewed, 5 or 6 of them, Marla? And we were kind of like, gee, this is, we found 1 or 2, but if you really looked at the applications of the people that we reviewed, they really wouldn't have fit our job model. I think most of you by now are aware of what the core competencies are that have been put into practice across many spectrums. Is anybody not familiar with those? Maybe that's a better question. There's a handout too. I don't have to tell all of you. These are just one of a little bit of the things that you do every day. Just thought I'd put some pictures up there just to show that, yes, sometimes you're in the office, but sometimes you're everywhere else. And that's exactly what our navigators are like. Qualifications, again, this comes from the C3 project. I think we went over this enough, so I don't want to browbeat this any more than we need to. But again, it's in your manual. Curriculum content, again, this is from C3 project, is it not? I think so. Or did we just come up with this? Yeah, we added some stuff. So, we just go, again, general concepts, community health concepts, all the things we kind of talked about, the healthcare system. We went over this, I think, pretty much in the last 3 days.
We do want to emphasize, if you've already figured it out, there are generic community health worker curricula out there. We came up with our curriculum on our own. We didn't really go out and copy anybody else's curriculum. But now what we think we have is unique is this sickle cell community health worker curriculum. That's you can plug it in. And imagine plugging in CH or plugging in diabetes, or plugging in some other thing. It's a model for chronic disease management. If you're really entrepreneurial and you get it down well for sickle cell, and there's a need for another disease process, there's an opportunity. So your first grant is taking community health navigator concepts used in managing sickle cell patients to name a disease, diabetes, and so forth. Maybe there's no need for it, but maybe there is in your state, in your region. Maybe there's a need for it. So it's a way for you to expand your scope of work and income stream.
So again, based on the C3 project, we try to use these tools as a way of hiring and training and making sure that, you know, navigators or community health workers are the best fit for what we're trying to do. So obviously great communication skills, relationship building, very important, service coordination, capacity building, facilitating and educating. I think Marla and Stephanie touched on that a little bit when they were talking about how they do try to educate their patients on taking their medications properly, some things to know about their disease, all those kind of things. Patient and community assessment skills. So we do this, I think, on an informal basis, not so much on a formal basis. The navigators do not do like the PHQ-9, which I think someone said that they do, or you're certified in doing in North Carolina. We kind of leave that up to the clinical social worker, but of course they believe, and I concur, that there should be some assessment skills that the community health workers are able to do, and whether that requires additional training, which I think is great. I'm really looking forward to what you send us, because I think it could really help our movement, at least in Virginia, and maybe through some of the other states as we continue to partner. Obviously, outreach, professional conduct, knowledge based on sickle cell disease. I always say this: we can train you on sickle cell disease, like I've said 100 times. We can't train you on your attitude. And evaluation and research skills. I wanted to know if you all felt, I had put this in early enough in the presentation, probably long before I realized how much we actually were going to be talking for the last 4 days. Do all of you feel comfortable, and if you don't, that's fine. Do you all feel you need some help or guidance if we do a practice job description? Or are you thinking that you're okay with all the information that we've had? We did put a copy of our VCU job description for our patient navigator in your binders. But if you think you need some assistance with that, I'm fine with us doing this exercise. So can I have a show of hands if you think this is something we need to go over, or are you okay with what we've talked about and what might be in your manual? I'm sorry?
Example in the manual, I think that's great.
Good? Okay. And of course, again, that's what we put in ours, and you can adjust it as you need to. So, even though when you work on the health system side, you cannot be part of research, you can be part of the evaluation process. So in our university, if you are hired as a health system employee, you're not supposed to be conducting research. But you are able to contribute to the evaluations, which in turn are things that you use in research. So the first thing that anybody does when they walk into our office is they get city trained. Does everybody know what that is? I know. After you do it the first time, you usually could go through, you don't know? So city training is open to most everybody if you're affiliated with the institution, for sure. I can't recall if you're in a community-based organization if you can go in and do it. Dr. Smith, do you know?
I'm sorry.
I think you need to get affiliated with something. If you're in a CBO, before I answer Ron's question, can they go in and get city trained?
Do CBOs need city training? Is that the question?
No, can they get city training as a CBO if they would want it?
Yeah, it's all about money.
Okay. So basically what city training is, Ron.
It's a for-profit institution.
So somebody's paying for, like our institution pays for staff to get city trained. I guess that's a better way of putting it.
Well, okay, so that's a different question. Can a CBO utilize the university's license and get city training under the university's auspices? Heck yeah. But that's an arrangement.
That's an MOU and all that kind of stuff. So what city training is it's a bunch of modules on different areas. So there's like a general, the general practice one that we all get, and there's a basic human subjects research one that we have to get. So if you are affiliated with a grant, especially a federally funded grant, you have to get city training. So you get it, and I think that some of them last 2 years, some of them last 3 years. And they're a bunch of modules, and you basically go in, and it takes you probably 3 hours to do each group of modules to finish one section, but you could take each module individually multiple times over.
And take the test first.
Yeah. See what you know.
Don't read all that.
Yeah.
Take the test. See what you didn't get right. Selectively read. Retake the test.
Who do you see at the university? What do you mean? Oh, it's online. It's online. Yes, ma'am.
So I just want to add, like Dr. Smith said, so we, myself and Dion, have actually done the city training, and I know that some of you guys with CEOs were asking about HIPAA. It's definitely there, and that gives you that.
They definitely have a module in there that goes over HIPAA, and it's very long, not the HIPAA session, but exactly like what Shirley said.
And you can break them up.
Yes,
You don't have to do them all
yeah,
at one time.
but it's definitely, but our researcher, gave us all that, so, yeah.
Yeah, it's a good tool to have if you
Who
think.
paid for it?
Who paid for it?
Yeah, who paid for it?
So I'm guessing the Department of Pediatrics.
Yes, so our PI, of course, is so.
The Department of Pediatrics
Okay.
at VCU.
Because you're under the PCORI grant, that's why.
Yes.
Okay,
The
that
department,
makes sense.
okay, you get it?
And that's appropriate.
Yep.
So the other thing, this is how I try to orient navigators to our job. So now that we have this training, this is going to be the new orientation for our new patient navigator. But what we had been using was our R18 training that we did in 2013, which wasn't as great and sure as heck is outdated, but at least there was a lot of information about disease, nutrition, hydration, exercise, community health workers, confidentiality, HIPAA, some of those things still kind of play true. I also really rely on Marla and Stephanie. They're great about taking students, interns with them around the hospital, and I'm always somebody who really learns by seeing, and I think that that's been really useful. And it's also useful to people who are not affiliated with sickle cell. And let me give you an example of why that's true.
Sure, would you use the mic?
Oh, all of our, back in the day when we hired navigators for our research project, we sat in this training, everybody sits here, you take your notes, and they may or may not have known what sickle cell disease was, that was fine. But they didn't really have an understanding of a patient who was well and then a patient who got sick. So what we decided to do, is we really became aware that they couldn't comprehend the difference, is we said, we want you to come to the clinic and we want you to meet a few people. And then when those people were admitted to the hospital, we asked them to go see them there. And they just had no idea.
It was amazing.
And so it's just important to me, and because they're always out and about, they don't ever have an issue, they just take people with them. And it's an on-the-job training, and they are able to provide them feedback, they're able to see them interact with patients, what questions are appropriate, at what time, if they're well and they're in the community, obviously they're more talkative. But when they're not well and maybe they just had been admitted to the hospital 12 hours earlier, you might just want to pop in and wave hi, even if they just don't open their eyes, but they want you to know they're there, maybe, or come back in like 5 days. So that has been really, really a positive. And now we have these things called talent goals, so we measure employees' success based on our annual talent goals that we come up with. And if possible, and now we have a better pre and post test. We'll be having staff taking pre-test when they get started, and then after they go to the training, taking post-test. Again, this is talking about performance evaluations at the university level and how we kind of review those together and come up with our goals. We talked yesterday about the do's and don'ts for the role of the navigator, and even though we really haven't put this into practice so much in the medical home, I think it's probably not a bad idea to put it back out there. But most of the patients do know by now what the navigator role is, but in the grant, we really wanted to make sure we weren't, putting people in difficult positions. So I would highly recommend when you're first starting out a program doing something very similar to this. Anytime you're sending someone out in the community, you want to make sure the expectations are aware of what they should be doing as an employee and what the client's expectations should be of them when they get there. And it's also a safety thing too. We went over that. There's all kinds of teams, but there's no I in a team. And if you're working as an I, you probably should not be working as a community health worker. Does anybody disagree with that? I think that everybody does their best to try to be accommodating to their colleagues, and therefore it makes the team work. So there is, when I went back and I did some research for this, there was a great template to use about how you want to develop your team. So obviously you want a strong team, and you want individuals to be able to flourish and use and develop their own strengths. Everybody comes up with their own styles of how they want to do things, and as long as it works within the practice, that's fine. Again, build relationships within your team members. You don't always have to like everybody you work with, but you have to be able to professionally get along with people you work with. And then outside of work, if you don't want to talk to them, that's up to you. But at least in the setting of a professional setting, that's why the team thing is so important to me. When I sit in on interviews, even with stuff that has nothing to do with me, I want to kind of see how I think they're going to fit. And an interesting assignment that I did is I had our intern who was here the first 2 days, our MSW intern, sit in on our nurse practitioner interviews, because she kind of was able to gather in a short period of time what was really important to our group. And I said, well, I want you to give me your analysis of how you feel these applicants were. And she came out and she basically was like, well, this, and this, but that person is not going to gel with your team. And that was the exact same impression that I got, but it was really nice to see that they were already able to observe what kind of, personnel we wanted to join our group. Align, of course, your efforts through effective communication of purpose so that the strengths are combined with the teamwork to achieve the results. Everybody's good at something, everybody's not good at everything. And also try to make sure that you achieve your performance results, because again, everything boils down to what you need to show somebody about the efforts that you do. And that's not just in this role, it's in any role. Any job that anybody has these days, you have to be able to prove that you're, like Ray was saying, sometimes you prove your value a little bit too much and you still don't get the respect that you need, but at least you know you're giving them all the things that they want. So I feel that we've also talked about a lot of these things over the last few days. They're in your manual. I think we all kind of concur that these are things that are really important. I always look to my leader, which is Dr. Smith, to help guide me in the things that I should be doing. And then I in turn hope that I provide that leadership to the individuals that also work in our program. We have visions, we talk about things, there's ownership about what we do and don't do right. We try to be respectful of timelines. I think we really try to be respectful of diversity here. And I'm pretty transparent. I let the team know very much when I'm frustrated with certain people at different levels, and they kind of always know what's going on. At least I try to keep them in the loop. And of course, good communication. Oh, and generosity, giving credit where credit is due. So again, this comes back to leadership. We kind of went over that a little bit. Visions of the project, kind of skipping through this. Good communication. Joan did a really, really great presentation yesterday. I guess we just want to continue to go through the key things here that we feel are important. And of course, my one that's really important to me is empathy and trying to recognize that each person is heard, which is not always easy when you're a supervisor. But you try to at least do what you can to make people feel like they're being heard, even if you can't always give them the solution that they want. Again, we talked about this. I think, and what I've noticed a lot too is within our team, there's a lot of kudos that are given. We do a lot of texting, like we were telling you, and there's a lot of good positive feedback that they do, that everybody gives to one another, which I think is also keeps people going, especially on really rough days. We do some positive team building, probably because we've all been together for quite a while. We probably don't do it like we would have done back in the day, because this is a presentation I gave, I think 3 or 4 years ago, but it's still something that, you should be offering your group as you can. But like I said, like I think the North Carolina group, you all been together for a while. You still want to have positive team building, but you might do it in a little bit different way. Supportive work environment, I think that's always great. Make sure you like coming to work every day. If you don't, you need to tell somebody and we need to try to fix it. Direct autonomy, I kind of went over this with you yesterday, that I believe at some point in time when you're trained and you know what you're doing, that you're an adult and you're a professional and you should be treated like one. And again, I don't like to micromanage, so as long as you know what I expect of you and you are in turn able to fulfill your job, you come into the office every day and you start your job. I'm still here if you have any questions or you have any comments, but you kind of should know what you're doing by that time. And I think people kind of like to work like that. I hope that you all do, but if you don't, then maybe you need to make sure your supervisor knows you might need a little bit more hand holding, especially when you're starting something and you're not really sure about it. I absolutely love the little engine that could, and there's also days, probably more out of not that I look like the lady that's on the other side of the page there, but you know, some days you're frustrated. You're frustrated with administrative things that you can't change. If you might have a person who is not really reliable coming to work. I think I shared with you at the beginning of our grant, you know, we had a lot of turnover because people, when you were hourly, they kind of didn't feel like you needed to follow a schedule. You could just come to work when you wanted to, not come to work when you didn't want to. This, Stephanie, I'm not talking about you. You know, I'm just saying about, in general, we had a lot of attrition because of that. And there was a lot of, you know, things that kind of made the boat move a lot slower. You know, always giving excuses of why you can't do something. Hostility among the team is never a great thing. Lack of interest in your job. I think if you're at that point, maybe you need to look for a new one. And lack of initiative. I don't feel anybody on the team that works for us has any of that. I think everybody does the best that they can and then some. We set the tone.
Set the tone for our organization. I'm going to say organization because it's a small group, but the tone is something like this. When we hire you, we're preparing you for your next job. We're assuming you want to grow. We're assuming you want to expand and do whatever the next thing is. So we are expecting high performance and creativity and ingenuity and entrepreneurship. That's what we're expecting. So we're not looking for you to punch a clock. In fact, if you're just punching a clock, I really don't want you. Because you're going to drag me down. Well, do I do it this way? Can I leave at 5:04 instead of 5? I don't want to hear that. What I want to hear is, oh, I found a new grant. Let's go for this. What do you think? I'll help you. So that brings morale, team morale up, and also makes you look really good when you go to that next job. The letter I'm going to write for you is going to look real good. So Shirley knows this is what we are telling everybody who comes to work for us. Even in the job interview, we don't wait until they're hired. We tell them up front, look, if you can't deal with uncertainty, and if you can't deal with almost topsy-turvy entrepreneurial environment, don't come here.
I also want to kind of reframe what I said. Stephanie was an hourly employee for us for 3 years, and she did not operate that way. I don't want her, you know, to think that Stephanie was doing something. Stephanie, I want to make sure you understood what I meant.
On the contrary, Stephanie, the passion showed through.
Yeah.
And we saw her, without telling us, we saw her saying, oh, I'll do this for free. Of
and
course, she didn't mean
that.
But the attitude was, oh yeah, this is my calling. I'm in my zone. So, thank you, Steph.
Stephanie likes the later schedule. So Marla gets in early and leaves at her time, and Stephanie usually gets in a little bit later and stays later, which sometimes has really worked out well, because if there's a situation going on in the morning, Marla's usually there, and if there's a situation going on a little bit later, Stephanie is usually there, so it has worked really well. I'm kind of interested to see how a third person's going to fit in. So, you know, again, same thing that we talked about, flexibility, adapt. Dr. Smith just went into that. You know, conflict resolution, this was, Joan really wanted me to put this out here. I think it is important. How you learn to resolve conflict amongst your peers are also an important thing. I love that if you have a problem that you try to work it out within yourself, but if you can't do that, then of course we're here to help you. And ultimately, we want everybody to try to leave as satisfied as you can be. I know that doesn't always work. So, you know, you have the upset employee, you have the supervisor, and then you have the other parties that are involved. And I've had to face this situation several times in this role over the last 7 years, and it's really ugly. I don't like it. And I'm somebody probably like Joan. I do get frustrated with myself, but I try to be positive around other people when I can be. And I feel really bad when somebody doesn't like a situation that's going on at work, and then you got to try to figure out a solution for that. So it's not something that we like to do, but we unfortunately have to do that sometimes. And like I said, there was several years ago, it was a pretty tough boat there for a while. And boy, you know, I was the one who was miserable. And no matter what was going on, nothing seemed to change until you got rid of the problem. And that was the only way to really change the environment. So, you know, think before reacting, active listening, obviously all the things, accept responsibility, direct communication, look for interest, the normal things. I told you, I always admit at least 2 to 3 times a day that I goof something up. I appreciate when other people tell me that they've done something wrong and you learn from that. I think we're all human. Anybody who thinks they've never made a mistake here, gosh, good, I love it. I want to take lessons from you. You know, again, you know, try to bring a solution that's friendly, hopefully, even if there's nonverbal changes that people make, sometimes that's all you need if you can't actually admit that there's a problem. If there's conflict of resolution, you know, sometimes you might have to get a third party involved. Hopefully that's not the case. The last place I want to try to ever go for anything that's involving members of this team is to the Human Resource Department. That is the last place I want to go. And let me tell you, they don't do anything to help you. So, you know, again, why is there conflict? I mean, there's all kinds of reasons why we can have conflict with people. And when should you resolve it? I think when it gets to the point that you no longer feel that you can live with the situation, and maybe you gotta try to do it before it gets to that point. But, you know, when there is more serious problems, you know, you do have to take situations that are not within your means to other people, and, you know, you try to have either a meeting with your group, maybe bringing in a neutral person. Has anybody been in a situation like that? Have y'all been, how did it make you feel? Yeah.
I've been in a situation where I actually overheard, this is when I worked as a research coordinator, another research coordinator talking about me when I returned from being out for 2 weeks because I had acute chest syndrome.
Okay.
And I didn't get upset. I didn't say anything, but I emailed our PI, and I recorded it on my iPhone. Yeah, right. So I was on the other side of the cubicle, and she didn't know I was there. I heard her, I recorded it, and I sent the recording to our PI. Our PI called our co-PI. We had a meeting, and it was just interesting being on a side of the table where I knew I was right, and then seeing someone trying to defend their wrong and being highly emotional and crying and like boo-hooing, and it's like, so I've been in those situations where it was like really serious, but they were the one like crying and needing consoling, and like all of these resources were given to them. And
I can relate to that. A couple weeks ago, Thomas and them can probably understand where this comes from. We were doing some filming on ACC4. So I emailed the lady that I thought was running the clinic, and she was on vacation. And I was busy trying to get this conference ready. They were coming in. I was trying to get all this procurement stuff done, all the things that, you know, you have to go through. So I didn't think to email anybody else in the clinic. And we show up and we want to do some role playing in the infusion center because we're going to have this new infusion center. So we wanted it to be in that introduction thing that you guys saw the very first day. Well, the nurses are in there. There's not a soul in the infusion center, let me just say that, okay? There wasn't anybody coming in anytime in the near future, but I rattled them and they were justified. And so instead of arguing with them, I'm like, you know, guys, come on, let's just move out of there. We'll go do something somewhere else or whatever, right? So it all gets worked out. Well, I get this nasty email on Monday from this lady, and not only does she just have to go through all the things that I don't know about everything that's going in the clinic, but she just has to basically like just go down the line. And I said, you know what, you are absolutely right. I did not notify anybody else. Okay, we made it work, it's over. Like, but you know, I guess she thought that I was gonna like argue with her, and I'm like, first of all, I have no time or energy to argue with you, and second of all, you're right, I was wrong. And the other thing that I thought was that the VCU media people, who we seem to be paying money for, but they couldn't like promote our conference and all that kind of stuff, well, that's a whole other conversation. But I thought they were notifying the clinic. So when I was just doing my respectful, hey, we're gonna be there, just wanna let you know, I'm kind of thinking the VCU media people are going in there and kind of making all the arrangements because they made such a big deal about, you gotta make sure everybody signs their releases that are gonna be there, you gotta make sure you don't film other patients. So I'm thinking that they've made all these arrangements, I was just kind of doing my little FYI kind of thing. Well, she was right, okay. All right, that was one check for that day. How many more did I make? I mean, that is just how it is. So sometimes you just got to bite the bullet, and sometimes you're right, you know, and that's just how it is.
To add to what she just went through, I went through something similar, and that person, for as many people that would listen and give her attention to the issue, just badmouth all throughout the area. And it's just unbelievable how a situation like that can snowball.
Oh, yeah.
And I just feel like it's so unnecessary.
Well, we're a gossipy group of Americans. We like to, women are the best gossipers of anybody. So, I don't hear too many men gossip. Really? I don't hear many men gossip. I just haven't met men kind of just sit back, cross their hands, and are like, there they go again. I don't know. I don't hear too many men. But we're curious people. Come on now, ladies. You know we're always a lot more curious. Yes. Well, we like dialogue, you know? But it's just a different style, that's all. So after lunch, Joan is going to touch on this, which I think is also very important in the jobs that we do. There is burnout, and there's a compassion fatigue component, and sometimes you don't always know what the difference is. So what time is it? A time for lunch?
Not quite. About 20
Well, let's go ahead and break early. Maybe the food is in there. If we can, if food is ready, let's try to get back here. What time are we supposed to start back up? We're supposed to start back at 12:25? All right, let's try to stick to that, but if everybody gets done a little bit earlier, maybe try to get back in here 12:15-ish or so maybe we can try to get the last part of the session moving and get everybody out for the day. Yes, ma'am? Yeah. Stephanie?
Everybody who did not have their bag last night, can I say
Oh, okay. Thank you, Stephanie.